USMLE Step 2 CK Hematology Part 19. There is a case. A patient has bleeding disorder. So what are you going to do next? Step 1. You order for bleeding time, PT and PTT. Result came bleeding time and PT is normal but prolonged PTT. And bleeding time normal means that patient does not have any platelet or vascular problem. And what is the next step you do? What are you suspecting? Patient could have clotting factor deficiency or the inhibitor of the clotting factor, like antibody against the clotting factor. Which one is the causing the bleeding problem for the patient? So step 3 is to know the deficiency of the clotting factor or inhibitor for the clotting factor. Perform the mix study, draw the plasma from the patient and draw the plasma from a normal person, and mix the plasma with the patient plasma with the normal person plasma and measure the PTT again. Result came normal PTT. Patient has the coagulation factor deficiency. So perform the coagulation factor assay to know that which factor the patient has the deficiency, like in hemophilia factor 9 or factor 8 deficiency, which causing the PTT increase or bleeding disorder. If the result of the mixed study came out that PTT is still prolonged, patient has inhibitor for the clotting factor 8, for example, it could be inhibitor of the factor 7, for example, or it could be lupus anticoagulant, also work as an inhibitor for the coagulation factor. So PTT is high after mix the normal person blood and patient blood. So step 5 will be how will you tell that PTT is prolonged due to lupus anticoagulant or the inhibitor of the clotting factor. Do the Russell-Viper-Benham clotting time test. If the Russell-Viper-Benham clotting time test is positive for the lupus anticoagulant. So SLE is causing the increase of the PTT. Note, lupus anticoagulant increase when patient has lupus. So know the pregnancy and SLE. Lupus anticoagulant cause the thrombosis in the vascular system. So what is cryoprecipitant? It is given to a patient who has fibrinogen deficiency. Cryoprecipitant has the fibrinogen. When fibrinogen deficiency, give the cryoprecipitate. Now the case is idiopathic thrombocytopenic purpura. Child and adult disease. In child, ITP, idiopathic thrombocytopenic purpura. We can write ITP. ITP could be acute and limited. In adult, ITP could be insidious and chronic. So ITP is an acquired thrombocytopenia. Lymphoma, chronic lymphocyte leukemia, SLE, or other connective tissue disease. Chronic infection from HIV, hepatitis B, hepatitis C, or history of the recent viral infection such as upper respiratory infection, most common to child, or live virus immunization, or idiopathic cause of the production of the autoantibody against the platelet. Cause intravenous platelet destruction, platelet antibody complex destroy at spleen. Cause thrombocytopenia. Patient develop hemorrhage. Initial clinical presentation. Cause acute onset of the bleeding in skin. Cause bruising, petechia, purpura. Oral mucosa, respiratory mucosa, including the nose, and cause the epistaxis, which may stop by prolonged local pressure. GI tract bleeding, urinary tract bleeding, vagina uterine bleeding, such as menstrual bleeding, rare intracranial bleeding, no hematosis. Hematosis occur due to clotting factor deficiency. If patient has severe hemorrhage, idiopathic thrombocytopenic purpura happen due to thrombocytopenia, not clotting factor deficiency. If patient has severe hemorrhage, patient may show anemic symptom. Child with viral infection did not have any episode of palpable bruise, deep muscle bleeding in the past. Child with viral infection and consequence from it to develop the idiopathic thrombocytopenic purpura would not have the adenopathy. Physical exam: petechia rash, bruising, purpura, ecchymosis in skin or in the mucosa. In trauma, patient has excessive bleeding compared to the normal people. No lymphadenopathy, no hepatosplenomegaly, vital sign is normal. So no adenopathy. Platelet count low. Rapid destruction of platelet low, very low platelet. If immune system destroy the platelet. Serum test, presence of autoantibody against the platelet. Bleeding time prolonged due to the thrombocytopenia. Coagulation study of the PT, PTT, fibrinogen will be normal. CBC, normal count of the red blood cell. If doesn't have severe bleeding. Low if patient lose massive amount of blood. So in this case, hemoglobin hematocrit will be low. So low platelet can cause the blood loss. Leukocyte count normal. This can tell that there is no pancytopenia. So bone marrow is not the cause to thrombocytopenia. CT scan or ultrasound to rule out enlargement of the spleen. So splenic sequestration is not the cause of the thrombocytopenia. Bone marrow biopsy, increase megakaryocyte and its activity, otherwise bone marrow is fine. No bone marrow fibrosis, no cancer cell infiltration, no infection in the bone marrow. Rule out the primary cause of the thrombocytopenia. So how you will treat this patient? Patient does not have bleeding in the central nervous system or GI tract. These two is considered very severe problem of the idiopathic thrombocytopenic purpura. If there is no central nervous system bleeding or there is no GI bleeding, and patient has mild bleeding is going on in other place and platelet count is less than 30,000, give prednisone before test for antiplatelet antibody or before the bone marrow biopsy to know the increased megakaryocyte. In another word, if patient has a mild bleeding, platelet count is below 30, give prednisone, and other if a For a few symptoms such as petechiae and epistaxis and platelet count is greater than 30,000, just keep patient on observation. No steroid treatment. It will be self-limited disease. You give the prednisone, still platelet count is very low, like say 10,000 to 20,000. In this case, do the splenectomy to save life. Still platelet after splenectomy, still platelet is very low. Patient has severe bleeding. Give IV immunoglobulin against the antibody which is against the platelet. So antibody against antibody. No treatment is needed. When child does not have severe symptom and platelet is greater than 30,000, child would recover without treatment. So don't give corticosteroid, just keep patient on observation. While keeping child on observation, if you see that it is take time to recover, there is continuous immune attack is going on against the platelet, give prednisone or immunoglobulin. Antibody production against the virus cause the destruction of the platelet usually is self-limited. When child adult shows severe symptom, a lot of bruising or platelet count is less than 30,000, give IV immunoglobulin against the autoantibody to rapid increase of the platelet and give short course of corticosteroid. If patient have GI or central nervous system bleeding, which is considered as a severe bleeding, and platelet count is less than 10,000, give immunoglobulin and anti-D. If any patient has active bleeding such as GI bleeding or intracranial bleeding, give platelet. Other case, avoid to give platelet because immune system will destroy this platelet. If patient has recurrent episode of bleeding and patient is dependent on prednisone, remove the spleen. If splenectomy steroids are not effective to prevent the bleeding, give rituximab, cyclosporin, mycophenolate, azathioprine. If splenectomy cannot prevent bleeding, give romiflostin, etormopag, and advise the patient to avoid trauma. Note: Idiopathic thrombocytopenic purpura patient has only bleeding in the skin or in the mucosa. Idiopathic thrombocytopenic purpura has no other health problem except the bleeding. Another note: secondary autoimmune destruction of the platelet cause the thrombocytopenia. A patient with SLE, which produce antibody against platelet, or has infection with the HIV, cytomegalovirus, hepatitis, Epstein-Barr virus, toxoplasmosis, can produce the antibody against the platelet. When patient has infection, patient could have lymphadenopathy, hepatosplenomegaly, and atypical lymphocyte. SLE will not have lymphadenopathy, hepatosplenomegaly, atypical lymphocyte. When suspect that patient has SLE and cause the thrombocytopenia, test for the presence of the anti-nuclear antibody in the serum to make sure that patient has SLE. First, rule out that patient does not have primary cause of the thrombocytopenia. If you suspect that infection is the cause of the thrombocytopenia, what test would you order? ELISA to find the antibody. ELISA test. This is the primary cause. Differential diagnosis also cause platelet destruction, no problem in marrow. Disseminated intravascular coagulation. Hemolytic uremic syndrome, thrombotic thrombocytopenic purpura. In idiopathic thrombocytopenic purpura have only platelet problem, but in DIC, HUS and TTP has anemia and thrombocytopenia because clotting cause the blocking of the blood vessel, which cause the destruction of the blood vessel. You will see cystocyte Hamlet cell. Another note, liver disease, cirrhosis, for example, patient has portal hypertension that lead to splenomegaly. Spleen cause the splenic sequestration of the platelet, and thrombocytopenia, blood platelet count remain above 30,000. So patient would not have abnormal bleeding disorder. So this is the end of this USMLE Step 2 CK Hematology Part 19.